movement disorders and Angelman syndrome. So the key will be dystonia and myoclonis. And like everyone else has disclosures, I'm also involved in some of the same trials that everyone else here is. And the most important thing is to mention, we'll be talking about medicines, some of which are off-label, which means we use them for things other than what the FDA says you should use them for. And I'll show lots of videos. All of these either are part of a study we did, or I have expressed permission from the families. And I always like his t-shirt. So as everyone has done a really good job of pointing out, there are a lot of different movements in Angelman syndrome. And again, the two I'm going to focus on are non-epileptic myoclonus and dystonia. Now, the way I think of the way I approach problems is thinking about first, what is it? What is it that we're seeing? What are the clinical symptoms that you were seeing at home? Why is the key part that has been discussed a lot so far today. Obviously, we know there's genetic underpinning with Angelman syndrome, but the last part of that is, well, what do we do about it? So my focus first right now is the what is it part. And so when I was learning about Angelman syndrome, there's non-epileptic myoclonus, and honestly, I was like, I don't know what this is. What do we do to figure it out more? So one of the approaches we took was to collect survey data from families and combine that with video data that families would also submit. And this is just a flow chart that kind of shows the approach we took. And one thing that came out early when I was really trying to work through this data is that about a third of families who submitted data reported that their family member had 3 or more abnormal movements. And so when we started to look back through the data, that made it very challenging to figure out what we're talking about. And so that's the same problem that we face as a community of what are we talking about? What are you describing? And the likelihood that the abnormal movement that your child makes is going to happen when you bring them in to see the neurologist is always low, and it never happens. Not never, but. So one of the things that came out from the survey data was 2/3 of families reported that the key abnormal movement was tremor. Now, we also looked at a cohort of 20 patients who family submitted videos. And when we had that group of videos reviewed by 10 movement disorder specialists, it came out that only 15% had what the movement disorder people would call tremors. With myoclonus, it was pretty consistent. But with dystonia, almost half of the videos reviewed showed evidence of dystonia, which to me was really interesting because at the time we started this study, dystonia had not been reported in Angelman syndrome, so we didn't know it was a thing. Now, I already told you this. Everybody knows what the videos. So when we talk about all these terms and we throw out, fancy language, sometimes it's easier just to say, here's an example. So this is an example of a tremor. And it's a very nice back and forth tremor. And you'll notice she's still able to eat her macaroni and cheese. She's going to lose a little here. And so, but for the most part, she's still able to feed herself. So it's a tremor. It's a little bit disruptive. But I think this is one simple point to make, is that for any of these kind of challenges, we should focus our treatments on things that are a problem. So, this is the discussion I would have with her mother of like, if this is not causing a problem for her, then I don't think we need to start a medicine to try to, fix what's not fully problematic. Now, let's see. So this is more an example of dystonia, and this was described well earlier. If you look at the hand positions, these are not typical positions we put our hands in. And so it's that combination of activation of flexor and extensor muscles at the same time. And sometimes as part of that, you can see there's a tremulous component to it, but it's not nice back and forth like we saw in the tremor example. And then here's just a finer, more in tune, zoomed in video of some hand movements where, again, if you notice the position of the index finger, it's kind of held out stiff. And so these are not typical positions that how we would, hold ourselves. Now, as part of that, you can have more complex movements. So this is an example of a young lady who her hands are distonically postured. She also has some kind of what I would call jerky movements that are consistent with myoclonus. Now, the numbers in the parentheses just point out that when you put a room of doctors together, not everybody's going to agree. And so that even makes it harder to say, to come to a consensus on what everything is. So this is an example of more of a myoclonus, of what we call a non-epileptic myoclonus. And so you'll notice, unlike the tremor, it's irregular. It's more herky-jerky. Unlike the examples earlier of seizures, though, you can see she's looking up and making eye contact with the person making the video. So unfortunately for her, she's aware this whole time that this is going on. It's just, you can imagine it's hard to get up and walk around and do the things you want to do when this is happening. And then, so here's another example with the same young lady where it's just a little bit more dramatic. And again, just points out some of the challenges that from a quality of life standpoint, this can really interfere with someone's life, including sometimes this can last for hours. And I'll skip to the second one because this is a young lady who had submitted multiple videos. She had video examples consistent with dystonia. She has an example consistent with myoclonus, but on the far right, she had an example that was myoclonus, but then turned into a bilateral tonic-clonic seizure, so the whole body shaking kind of seizure. So now, this just is an example of how challenging this can be because someone can have all of the above. And so it's really important to try to know what we are treating because that changes how we treat it. So after I started this work, a paper came out describing dystonia and Angelman syndrome. And I think what I thought was very interesting is that this is something that gets worse with age. It's not a problem in the younger children. And they described in their cohort of adults, 93% had dystonia. So for something that wasn't recognized until less than 4 years ago, it's become very interesting. And one simple question is, well, why didn't we recognize this? And I think part of it is, a lot of us, I'm a pediatric neurologist. These are challenges that tend to happen in teens and adults. And for a lot of people, the dystonia was relatively mild. And so in the scheme of some of the challenges they faced, for example, the young man sitting there that his hands were in kind of weird positions, that wasn't overly disruptive to his life. Now, I do think as we learn more about this, I start to wonder if some of the myoclonus is more of a mixture and more of what we call a myoclonic dystonia. And what that means is the underlying movement is a dystonia, but it has a myoclonic jerking component to it. And why why all these details become important is in clinic, there's drugs we use to treat dystonia, there's drugs we use to treat seizures, there's drugs we use to treat myoclonus, some of which are the same, some are not. So knowing what we're treating will be really important. And again, I reiterated this a little bit, but to point out, I think the key point for me is this, that when we were looking at some of the medicines that were used to treat, that we are surveying what medicines were used, when we looked at some of the classic medicines that might be used to treat a dystonia, of the 47 people who submitted data, only one had tried one medicine, 0 had tried another class, and a few had tried one of the other medicines. So it just points out these are things, these are tools that are available that we're just not using. So I'll talk more about this actually tomorrow, but there's a lot still that to me is important to know in terms of why does this happen? And those are definitely things we spend a lot of time thinking about, but I won't belabor that today. So the key, I think, here is spending time thinking about what do we do about dystonia and non-epileptic myoclonus. So I won't torture you with this entire table other than to point out this is some of the data that led to some of the basis for some of the things I'll talk about later. And basically, we asked families, so for example, this is separating out those who describe myoclonus, and these were all the phenomenological diagnosis is based on the video review. So if you had myoclonus, what are some things that made it better and what made it worse? Same thing with dystonia. And I'll summarize this all later. And then we use this same approach by running a list of medications and saying, did you try this medicine? If you did it help or did it not help? And so that's how we got to some of, again, what we'll discuss. So when I think about things of how to treat something, sometimes the best way to treat something is to not allow it to happen in the first place. So prevention is, I think, very important. Now, part of that is first identifying if it's not a problem, then let's not worry about it or start a medicine for it. Some of the triggers that families reported made these movements worse are sleep. And we know sleep is the definitive cure for movement disorders. So lack of sleep makes things worse. I'm a neurologist. I talk about constipation every day, a lot. And the point is that is another big trigger that also affects quality of life for many different reasons. And it's hugely important because if we treat the trigger, it improves other things. The same is true for anxiety. Anxiety can be a trigger. There's medicines that are used to treat anxiety. And then lastly, for some girls and women, there can be associations with changes in their menstrual cycle that can make movement disorders worse. It can also make seizures worse. If that is a major trigger, then there are hormonal treatment options that can be used to level out the hormones. So again, focusing on trying to not let these things happen in the first place. Now, this little guy is to point out, this is my picture of a magic bullet, and to point out, I don't have a magic bullet. I wish I had one pill I could say everyone could use and it would make this go away. So what we have learned is many of the same medicines we use to treat epilepsy can be helpful. So benzodiazepines, that includes the medicines mentioned, clonazepam and clobazam, are some of the more effective medications. Levetiracetam, there's a lot of discussion about valproic acid, which is really interesting. It can be very good, but it also has issues. It's an old medicine though, so we know the issues well. It's just they can still be issues. And then some other medicines that were discussed, cannabidiol, Perampanel is a newer medicine. I'm not sure how available that is worldwide. And now when we get onto movement disorder medications, the one that we've had some success with is called trihexyphenidyl. It's another very old medicine, so we know it well, but we also know that some of the side effects can be problematic, including concerns for making constipation worse and potentially having people hold on to their urine. So again, there's good and bad side effects of everything. And then, if you notice, I have asterisk. Oh, I went backwards. Yes, it's all right. Oh, I went forwards. Sorry, laser. All those asterisks represent medicines that I think could be helpful, that are common medicines available that neurologists use all the time. It's just we don't yet have the data to know that I can reliably say, if we start this medicine, it's going to be helpful. So that's some of the key issues that I spend a lot of time thinking about, is how do we study these things and have a better idea of what is going to help and what has low side effects. And the thing, and why I focus on these types of medicines, is because I could start someone on one tomorrow. They're medicines that have been around for years and they're readily available. So it's just, I think, important to think about. Now, many of this, again, I'm basically saying what was already said, and this just demonstrates, for seizures, we have rescue medicines and different approaches we use for if there's seizure clusters or if there's prolonged seizures. One of the good news is a lot of those same medicines are the exact same things we can use if somebody is having more of a myoclonic crisis. Now, there's also a few other tricks, including since sleep, there it is so helpful, if somebody is on effective sleep medicine, give it early. If they go to sleep, that will make the movement stop. Now, again, there's things I wish I had data on, but Benadryl, so diphenhydramine, is a medicine that's used frequently as a sleep supplement. Some families report that it also helps in these kind of crisis times. And it may be that it's because people go to sleep, or it has some chemical properties that are similar to the medicine trihexyphenidyl. So there may be more to the story, we just don't know. And then we'll bring this up because I think relevant to clinicians, that again, many of these same treatments are available if somebody would end up in the emergency department and where we can give IV medications. Again, a lot of the same medicines that are used to treat prolonged seizures can also be helpful for myoclonus. So I still think there's a lot we need to know. And some of the work that we want to do going forward are, again, better understanding the movements, work on outcome measures, and trying to figure out how we study this more. Because to me, it's something that is going to be extremely important that we think about these kind of movements in future clinical trials. That are the treatments that are being developed also work for some of these additional types of movements. We're actively thinking about either devices or artificial intelligence and ways to quantitate these types of movements. So we can have actual data that says the treatment I did made things better versus using a journal approach. And then, of course, there's a lot I would love to know about the underlying reason why these things happen. And so this is just an example that I think is really interesting, and hopefully, well, we're going to see it backwards. So this young man, well, I'll jump ahead. So on the left, he was having some mild myoclonus, but it was preventing him from doing the things he wanted to do, and he was clearly unhappy. He was, and I don't know, if I go back, I can now play the other We'll see if this works. Oh, there we go. So I wish I had the volume because now he's talking with his caretaker. Clearly he's happy. He's back on his tablet. He's able to manipulate it. He's interactive and smiling. And the difference was, this was 20 minutes after he was treated with a medicine called propranolol. Propranolol is a medicine that's used for many different things, including abnormal movements, blood pressure, migraines. It's probably been around for 20 or 30 years, if not more, and is readily available. Now, because it helped him, does that mean it will help everybody else? I have no idea, but that's what I want to know. So this is the team that's worked on a lot of this project with me, but I think the most important thing that I want everyone here to know is that almost everything that I've been focused on clinically has been driven by families and sitting in clinic and having a conversation and having a family identify a problem. And in the search for questions is what drives most of us, or the questions and the problems and how do we fix them. And so keep talking to us. I promise we do listen, and we do our best to, if we don't have the answer, to try to figure out what the answer is. So thank you all for coming.